Hi, everyone. Let's take a moment to go over some disorders of the immune system. These disorders can be divided into primary. Generally, those are congenital defects that result in abnormalities in immune response. And there's also acquired immunodeficiency syndromes. Okay, speaking of primary deficiency syndromes, there are a few that we know about with differing severities. One of the diseases that manifest in one of the most serious presentations is called SCID, or severe combined immunodeficiency. This is something that seems to be genetically determined, and you can, in general, suspect that there is a difficulty in immunity when you see recurrent or persistent infections beyond the first 6 months of life. And that 6 months is important because prior to that, when, first of all, the infant or the fetus is gestating, you'll see passive immunity develop in that immunoglobulins, these T cells, B cells can pass over the placental barrier and exist in the fetus and then infant upon birth. If the mother is nursing the infant, there are also immunoglobulins that can be transferred passively through the breast milk to the infant. So essentially that's passive immunity in that the infant doesn't have to do anything specific to acquire those immune capabilities. After the 6-month mark, you need the immune system to kick in and start making its own immune cells to combat various antigens in the world to protect the infant. If you see these recurrent or persistent infections, what that tells you is that there is some possibility that the passive immunity transferred through pregnancy and or lactation is not being replaced by the immune system of the infant. So you can suspect at this time that there is a possibility that there's an immune defect. Okay, for this severe combined immunodeficiency, this is a disorder where there is an error, a genetic error that leads to the inability to effectively manufacture T cells and B cells. And if you've learned about the immune response prior, you know that T helper cells especially are required to begin or help start the immune response. And B cells are very important in mounting the antibody cascade and the creation of antibodies through plasma cells and then memory B cells. If you don't have these things, you get a decreased immune response and then the inability to fight infections. There's different severities of this, and the most severe was present in a figure that movies have been made about, but was a real patient. This is also referred to as bubble boy disease because of one of the first cases observed in this individual named David Vetter. He had the full spectrum of SCID, meaning that he was unable to produce these immune cells and then was extremely extremely at risk for contracting disorders that he then could not fight. So he spent 12 years of his life in this plastic germ-free bubble, in that he had a complete block in T cell development. Once we saw the technology and the treatments for this change, he was able to leave that environment. And there's great writings about his first time, for example, being outside and just taking in all of the things that we see every day and maybe take for granted, like trees and grass. So this is something that we can mount some sort of treatment for disorders such as SCID have come quite a long way, and one of the primary ways that these disorders are dealt with is in stem cell replacement or in a bone marrow transplant. For these immune cells to be developed, you have to have healthy marrow, and you have to have a couple of different precursor elements, like vitamin B12 and other things, like folate, to encourage these stem cells to differentiate and then mature into immune cells like B cells and T cells. If somebody's marrow is incapable of doing that, they are a likely candidate for stem cell therapy or bone marrow transplant. In this treatment, you first see a patient with their existing marrow that is ineffective in producing these mature cells, these immune cells. The first step would be to ablate or delete or remove, essentially, their existing marrow. And this is done with chemotherapeutic drugs or radiation therapy, which you might be familiar with through its reputation with cancer therapeutics. But the way that these different drugs and therapies work is to physically destroy parts of existing cells. And they are used selectively, kind of, we'll talk about that later, in cancer therapeutics to destroy tissues. So in this case, we start with chemotherapy radiation to physically destroy the existing marrow that either abnormally or is unable to create these cells that are needed, these immune cells. Once that ablation occurs, the patient can receive the donor marrow. So these stem cells are taken from a donor essentially with their blood. So when you donate bone marrow, it is harvested and then brought into cell culture and incubated with antibodies. Those stem cells that bind antibodies are purified out, they are collected, and they are brought into a dilution that makes them safe to put into that specific patient. So specifically, the bone marrow can be completely donated essentially and implanted, infused into that patient. And the hope is that the marrow that was defective can be replaced with effective marrow from a donor. Before we go on, let me just mention two other disorders that I didn't before. There are two congenital disorders of the immune disorder type. There is something called Bruton's disease, and in this specific congenital defect, there is an inability for B cells to mature. So these individuals have almost no circulating immunoglobulins because B cells are the ones that are activated to differentiate into plasma cells and memory B cells to create antibodies. If B cells are unable to mature, then we are not going to have these capabilities of the B cells. So we can also have immunoglobulin infusions in Bruton's disease. Second, there is DiGeorge Syndrome. This is another congenital defect. And in DiGeorge Syndrome, there is, in some cases, a complete lack of the thymus, and the thymus is where T cells go to mature. So in DiGeorge syndrome, there is a T cell abnormality. So these can all be treated in the bone marrow transplant route, replacing the ineffective or malfunctioning marrow with healthy donor marrow to hopefully get the creation of healthy immune cells. Okay, and then quickly, secondary deficiency syndromes. These are cases where there's an immunodeficiency because of some other reason that is not development related or gene related. So some different causes of secondary deficiency. First off, they can be metabolic in nature. And in these cases, this can be because of either malnutrition and a lack of things like folic acid or B12, these really important ingredients in the creation of blood cells, one of those types of blood cells being immune cells. Also uremia, which emia is blood flow, so that is a high amount of urea, uric acid in the bloodstream, which crowds out and changes the acidity of the system. And I said crowds out because we can get the crowding out of a typical immune response. You can also see this in cases of diabetes. We talk more about that in the endocrine chapter. There is iatrogenic, so that means created due to medical treatment. So some sort of medical treatment that happens in a hospital or primary care environment causes this deficiency. And as I mentioned before with chemotherapeutics and radiation, these drugs, like we see cisplatin right here, causing DNA damage, some non-apoptotic cell death, possible apoptosis. So these are medications that can physically destroy cells. The way that chemotherapeutics in general, the very basic level work is that they target cells that are rapidly dividing. So for example, there's a cell phase called the M phase, M for mitosis. So there's 3 tissues in particular that are most likely to be in a mitosis phase. They're the ones that are renewed most often. The first being the epithelium, so epithelial cells. So that includes things like the lining of the GI tract, which is why in chemotherapy you see difficulties with digestion. You see this with hair, and then you also see this with marrow. And marrow is very rapidly dividing because those stem cells are dividing into red blood cells, white blood cells, immune cells. So it is likely that they are targeted by these drugs, these medications that are meant to ideally target tumor cells that are rapidly dividing. They're pretty non-selective in that way, in that they will kill any cell that is rapidly dividing. And the marrow is very at risk for that. Another medication that causes immunosuppression in general because of different activity of the medications, like cortisone, or which is changed into cortisol by the body, cortisol being the natural hormone that's released in response to prolonged physiologic stress. These medications, when given, they suppress things like natural killer cell activity, macrophage activity, and just immune function then in general, because we know macrophages, those are the cells that end up starting the immune response just by coming into contact with an antigen. So we get these depression of cytokines responsible for activating immune cells in giving immunosuppressant medications. We have malignant tumors, which can affect immunity and cause a deficiency, especially malignant tumors within the marrow itself. We'll learn more about cancer types later, but the basics of what cancer cells do is they're rapidly dividing cells of a tissue. So they're not like brand new cells that appear out of normal. They're existing cells that should be making copies of themselves to become things like new marrow cells, for example, or new liver cells, but there is an error. And then we get copies of these abnormal cells in that area. So in cancers within the bone marrow, for example, we'll get the replication of these tumor cells, and those will effectively take over the location and then the function of the good marrow cells. So they replace the normal tissue with this abnormal, dysfunctional neoplastic tissue. We can see a variety of viral infections cause immunosuppression. We'll talk about HIV in just a second. Measles, and especially infectious mononucleosis. You might know that as mono in general, and that's an infection specifically of B cells, which eventually leads to their destruction, which is why it causes so much illness when it is contracted. So those can all cause secondary deficiency. The final one that goes along with this gross picture is splenectomy. Ectomy means to cut out or remove, and splen is referring to the spleen. So removal of the spleen, which is important for the processing of immune cells and really any kind of cell that needs to eventually be removed from the body, is done so by the spleen. So if the spleen is removed for whatever reason, that can cause abnormalities in the system and then suppression of the immune system. So the important thing about these to remember, these secondary deficiencies, you are not born with them. They are not a result of development errors. They result because of something else, something secondary. Okay, so finally we'll move on to acquired immunodeficiency. Acquired. So that you are not born with, it is not contracted by a secondary reason because of medications or the removal of an organ. In this case, this acquired immunodeficiency is a result of contracting a specific virus. So HIV is an infection that specifically targets a type of T cells. T cells, without them, we cannot have an immune response. The T helper cell is responsible for helping to mount an immune response. That's why we call them T helper cells. We also call these CD4 positive cells because they have a surface protein on them that is called the CD4 positive surface protein. So T helper or CD4 positive. All right, so what you see in this picture, it's a very simplistic way of envisioning what HIV does. So HIV is a virus, and one important thing to remember about viruses is that they in and of themselves cannot do a lot in the body. They need a host to infect in order to be able to use those host cell parts to make copies of itself. So this is showing you this HIV cell, which doesn't really look like that, but it's cute. And in this picture, it is attacking these T cells. And now we have HIV down here, which seems to have a little baby HIV. The main thing that viruses want to do in the body is replicate. And in this case, in this specific disorder, the cells that they use to replicate, because they're the ones that they recognize and infect, are these T helper cells, these CD4 positive cells. Okay, so HIV. Here I've got a picture of Magic Johnson, and the reason I have him in here is because a lot of people, especially my age, I'm 37, we remember, and maybe you remember too, depending on your age, when Magic Johnson was first diagnosed with HIV. For a while, HIV was something that was considered not even an immediate death sentence. So it was a disorder that we didn't know a lot about, we didn't know how to treat, and it led to death within a couple of years due to opportunistic infections, which take advantage of the fact that somebody's immune system is not capable of fighting off these infections. So HIV in and of itself is contracted in 4 ways. The first being sexual intercourse. And the types of sexual intercourse that make it more likely that HIV will be passed on is anything that involves blood sharing. So the lowest likelihood of blood sharing due to physical tearing of the genitalia or whatever organs are being used in the sexual act is female to female sexual contact, because there is a lower likelihood of tissue tearing. Then we have penile to vaginal sexual contact. Now we're getting up a little bit more in the likelihood that there will be damage to the tissues, and then the sharing of bodily fluids. Whether it be male-male or male-female intercourse, anal penile, In that case, there is the highest likelihood of damage to the tissue, blood sharing, and or bodily fluids being shared. And that is because there is not natural lubrication that is released in the rectum in the same way you would see it released from a place like the vaginal canal, for example. That means anything that causes even micro tears in the system due to friction can be minimized, first of all, with things like lubrication, which reduces the chances of friction, but most importantly can be reduced with a prophylactic device like a condom, which reduces pretty significantly the chances of HIV and really any sexually transmitted infection from being passed on. So that's the first one, sexual intercourse. Second, we have blood-borne contact. So that includes things like sharing of needles for injection, and that could be for drug use in general, and it can also be for therapeutic use. Syringes cost a certain amount of money. In some cases, they are reused. Sometimes they are shared. And that is obviously not recommended, but sometimes it does happen, unfortunately, out of necessity in some cases, especially in the United States. Other times it happens accidentally. So in healthcare environments, for example, putting the cap back on a syringe is one of the most likely ways that diseases can be contracted. So any kind of syringe, any kind of needle that had been used previously in somebody that then is introduced into skin a second time, especially in a different person, that introduces the likelihood of transmission of a disorder. So we've got our needle sharing, so accidental or on purpose. Then we have blood transfusions, so that would be the donation of blood that is then infused into another person. In specific things like collection through the American Red Cross, they do testing of blood. However, they also have some recommendations around individuals who engage in homosexual sex, male sex specifically. There are still laws on the books or rules on the books about how long somebody can wait after having male sexual contact and then donating blood. There is perinatal transmission, so that would be mother to child, also called vertical transmission. Again, this is all about fluid sharing. So there's a lot of fluid in childbirth, but again, mainly it's through the sharing of blood. Blood carries the highest amount of the HIV virus and then increases the likelihood of transmission when there's blood being shared with blood. So this is something that used to just be considered a given, that if a mother had HIV, that their offspring will have HIV just via the birth process. But there are definitely ways to prophylactically prepare for this, and there are definitely now reduced rates of HIV transmission vertically. And then the final thing is breastfeeding. There is HIV that is transported through breast milk. It is not as high as the percentage of HIV that's present in the bloodstream, but it is an amount. It used to be recommended that mothers with HIV not nurse at all their infant because of the risk of transmission. Again, there are ways to prophylactically prepare for this and for an individual to be able to nurse their infant while reducing the risk of transmission. So as I mentioned, like condoms and prophylaxis before, prevention is really the key to avoiding transmission. So utilizing prophylactic devices, so in sexual intercourse, using condoms, dental dams, finger cots, things that form physical barriers between two people. In medical research environments, any kind of hospital environment or patient environment, PPE, so wearing your nitrile gloves, latex gloves, wearing your safety goggles, those are all prophylactic ways of reducing transmission. One bodily fluid I didn't really mention is saliva. There is a trace amount of the HIV virus that's present in saliva, but I think the last time I read something, it was about 2 gallons that you need to ingest in order to get the adequate concentration of HIV to contract it. And there's really no reason you should be consuming 2 gallons of anybody's saliva, just as my PSA for today. So that is the rundown of how we pass on HIV. And I keep mentioning the treatments. The treatments for HIV are part of a family of treatments called HAART therapy, and that is short for highly active antiretroviral therapy. Highly active antiretroviral therapy. As we'll see written out on the next slide, HIV is a type of virus called a retrovirus. So the medications that stop or, to the best of their ability, prevent the copying of HIV into more copies of itself are going to target this reverse transcription copying technique that retroviruses use. You will see there's quite a bit of pills here in the picture. In pharmacology, we call this a pill burden or a medication burden, and it's one of the barriers to getting people to comply with their drug therapy. The more medications people have to take, the more times a day they have to take them, the more likely it is that they won't do it correctly. The more side effects there are of these medications, the less likely they are to comply with therapy. But when taken correctly, highly active antiretroviral therapy targets the various steps of viral reproduction in the body so that you can essentially halt or arrest the concentration of this virus so you have it at one concentration, and if instituted at the correct time, it is less likely that the viral load will go up because you're stopping it from replicating. Just a little note too, there is something on the market which you may have heard of called PrEP. PrEP is a medication that's a prophylactic, and prophylactic just means preventative. So individuals who engage in high-risk activities for the contraction of HIV, if they take this PrEP medication, there is a giant reduction in the likelihood of them contracting HIV because of the very targeted way PrEP works to prevent the introduction and the replication of the virus inside the host body. So it's very cool. Okay, very quickly, what is HIV? What is it? It's a virus. You don't have to know all of these parts unless your instructor tells you that you have to. If I'm your instructor, I'm telling you don't have to. So this is, again, HIV is part of the retrovirus family, which means it uses reverse transcription to make copies of itself. If you took cell biology, you might remember that transcription and translation relate to or describe the process of reading the instructions, the genetic instructions for making a new protein, and translation is physically creating those new proteins which make up the component parts of a cell. So I want you to notice that this HIV virus, there's not a lot to it besides its chromatic or genetic material in the center. So there's 2 strands of RNA, and then there is this lipid membrane portion and this enveloped receptor portion on the outside. I want you to notice you don't see any cellular organelles in here. You don't see a nucleus. You don't see an endoplasmic reticulum or ribosomes. That means that it does not have a functionality. It cannot do things that other cells do. It can't do its own transcription and translation. It's not possible. However, like every other thing in the known universe, every organism, it has an inherent drive to survive. It wants to survive no matter what at the end of the day. And for a virus, and HIV now in particular, that means finding a host cell to infect and then utilizing the machinery inside of that host cell to make copies of itself. So that would be similar to, let's see, there's not a lot of room on here for me to draw, but let's say I have a great idea for a new product. I want to make a new type of, I don't know, pen. There's me and my pen. I have groundbreaking pen technology. However, I'm just a girl with nowhere to make her pens. So what I have decided to do, I found a pen factory with all these happy pen people inside making their existing pens. They've got all the machinery they need for the pens, and they're churning out pens all day and night. And now I want to get rich and make $1 billion making my pens. So what I do, I'm a virus. I'm a pen virus right now. So I am going to break into this pen factory. I'm going to kill all the people that work there, and I'm going to use all of their pen making technology to make my own pens. Lots of copies of my own pens, get $1 billion, and be happy like Jeff Bezos. That is essentially the way that viruses work. They have to target a cell. They utilize everything in that cell, which typically goes to make proteins so that you can get copies of the cell and more healthy cells to do cell things. Viruses get inside and they use those things to just make copies of themselves. So in a T helper cell, for example, we know that T helper cells, they do all kinds of things like make T cell receptors that recognize epitope portions on MHC complexes presented by antigen presenting cells. They need to be able to do that. They need to be able to release cytokines and other things that help with the immune response. If a HIV virus gets inside of that T helper cell, all of the parts of that T helper cell, which were previously used to do T helper cell things, are now going to be utilized to just make HIV. So all of this normal functionality is gone, and this T helper cell is now an HIV making factory. If you do not have T cells, you do not have any of these other components that help the immune system. So we've gotten rid of all these interleukins, which help call things to the area, like lymphocytes and macrophages, B cells, natural killer cells. This is natural killer cells that engage in antibody-dependent cytotoxicity, killer T cells, macrophages. All of these integral parts of the immune response no longer exist because this T cell is now not a T cell with its functionality anymore. It is a T cell that just churns out HIV virus all day and night. So you see that there is a huge amount of effect, deleterious effects on the immune system as we get the selective destruction of these T helper cells. HIV is able to target these T helper cells specifically because it recognizes that surface protein, that CD4 positive surface protein. HIV, those little things you saw in the picture earlier, those surface characters, that looks really bad, sorry. Those surface characteristics of the HIV virus, they are selective for the surface molecule of the CD4 positive cell. That just looks like a depressed person now, and I'm sorry about that. Let's move on. Finally, you don't have to know everything, me at least, about HIV replication, but what this is showing you are the different steps of the replication process and what drug classes or drug types are used to target that process at each step. So one of the reasons you saw so many pills in that one picture of heart therapy is because people are taking generally medications that target different steps in this process. So here you have your HIV molecule. This is what I just drew. Doesn't it look the same? Yeah, it looks great. Okay, so here's the HIV molecule with its surface characteristics. And this part of the nuclear or the viral envelope with its little surface characteristic, again, it's specific for that CD4 positive surface protein, which you see right here. So there is this binding interaction that occurs. And then there is fusion of that virus with the membrane, and then the uncoating of the virus. So this whole coat is peeled off, and then all of the component pieces are out floating in the cellular inside, essentially. There's drug classes that prevent this from happening to begin with. So they prevent that fusion bubble from forming. Those are called fusion inhibiting drugs. The way that all retroviruses, and HIV specifically, make copies of themselves is this process called reverse transcription, and there are medications which block that called reverse transcriptase inhibitors. Also, so after we have this complex move into the nucleus, and now this nucleus doing non-T4 cell things. Instead, it's just pumping out genetic material to be incorporated into a new HIV virus. It is eventually going to bud off, and then we have another mature virus that can go out into the bloodstream and infect other cells. In this budding off process, there is a protease inhibitor class of drugs which can prevent that budding off. So just know that when people are taking medications to reduce their HIV levels, essentially these drugs are targeting the various steps of this viral copying, this viral replication, to decrease the chances of HIV copies being made. The less copies that are made, the less of the likelihood that that disease will be passed on. And also to the individual, the less likelihood there will be of the destruction of all of the T helper cells, and then an opportunistic infection coming in and making them very, again, sick. Okay, so just going very quickly through the progression of HIV, there is an acute phase of HIV, and then there's a longer term progression. And that's something that's really specific to HIV. You see this break in the line here after 12 weeks, and it goes off to 1 year. This is what we call a latency period. Oh, it's written right here, clinical latency. That means that the virus is on board, but it's kind of laying beneath the surface, making some copies of itself, but we don't see the emergence of any clinical symptoms just yet. Even though you don't see on the outside any clinical symptoms evolving or making themselves known, you still see quite a bit of things happening underneath the surface. Here on the y-axis, so this is a dual y-axis graph, very pretty. On the first y-axis, you have CD4, so these T helper cell counts in the bloodstream. And at the time of primary infection, you see that there is a pretty high number of T cells, which would be normal. That's a normal person who now has become infected with this virus that selectively targets their T cells. And initially, within the first few weeks, we see this massive decrease in the number of circulating T cells in this individual. And that's very characteristic of HIV. And during this time, there is an acute infection phase, which looks really similar to the flu, for example. People get really swollen lymph nodes, they don't feel great. But when you have swollen lymph nodes and a temperature, you don't immediately think like, oh man, I probably have HIV. It's generally just dismissed as cold symptoms, as flu symptoms. All right, so once that initial acute infection phase occurs, there's really not a lot of symptoms that really pop up for about 7 years. Again, HIV is really characteristically thought of as something with one of the longest latency periods that we know of, and 7 years is a typical latency period for HIV. All right, so after we get to a couple of years out, we're done with this acute phase, we don't see constitutional symptoms or things that you can observe and a patient suggests that they observe in themselves until about 7 to 8 years later. The problem with that is if we waited without drug therapy or anything else until the time where constitutional symptoms appeared, the number of T cells has dramatically reduced by this time. So ideally, you would swoop in with your pharmacologic intervention much earlier than having constitutional symptoms. Okay, on the other y-axis, we have HIV RNA copies in the plasma. So in blue, we are looking at T cell, and in red, we're looking at the HIV itself. So again, when we're looking at the initial infection with the virus, so during that acute infection phase where people feel sick, we see that there's a large amount of HIV replication and then HIV RNA that's measurable in the bloodstream. And then we see this coinciding with this clinical, I am messy tonight, I am sorry. We see the amount of HIV RNA go down really in line with this clinical latency period. So the virus really stops its active replication and then kind of goes into its own latency period until it starts to rise when, again, constitutional symptoms appear about, 7 to 8 years later. If there is no intervention and drug therapy is not instituted, you see that the most common cause of death is the infection with opportunistic disease, which the definition of is diseases that normally would not be fatal to that individual, taking advantage of the fact that there is a weakened immune system and then infecting that person, and we see really severe outcomes from that. So some things that we see associated with opportunistic disease or HIV infection in general, we have B-cell lymphoma as an opportunistic disease. We have the pneumonias, so pneumocystitis, so the pneumonias. And then we have Kaposi's sarcoma, which is a specific type of skin cancer, which causes these purplish dark lesions to develop on the skin and also intraorally. Those are the three most common opportunistic diseases that lead to death, unfortunately, in somebody with HIV. But again, because we have this really effective, highly active antiretroviral therapy, we see far fewer deaths, definitely in the United States, due to HIV infection because of the proper treatment and therapy. Okay, so that was your overview of our immunodeficiencies that occur either on a congenital basis, so they are inherited. Then we went through our secondary types of immunodeficiency diseases, and then finally we ended with acquired. And that's it for now, everybody. Stay smart.